The following episode is brought to you by the American Urological Association. This episode features content from the AUA 2026 meeting in Washington, D.C. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. Support for this activity has been provided by independent educational grants from AstraZeneca, Merck & Co. Inc., and Pfizer Inc.
All right, welcome to the AUA 2026 Spotlight, PARP-Inhibitor Combination Treatments for the Urologic Care Team, presented by the AUA Education and Research Incorporated. Obviously, we need feedback on educational content like this, so there's a lot of handouts there on the table about providing your feedback at the end of the course. We have an AUA staff team off to the side. Jody Donaldson is here on site. If you have any issues or questions, you can raise your hand and run over there to see if you can get something addressed. We'd like to thank the following companies for providing independent grants to support this educational series: AstraZeneca, Merck, and Pfizer. And I'd like to welcome three esteemed colleagues and faculty up on stage with me. Kristen Scarpato is Associate Professor of Urology at Vanderbilt University in Nashville, my hometown. Pedro Barada, board-certified fellowship-trained medical oncologist, but we won't hold that against him. He's here from University Hospitals at Case Western in Cleveland. And Kara Kosis, a PA with Chesapeake Urology, one of the first independent large urology group practices in the Maryland area. So I'd like to thank you guys for joining me. There are disclosures for all of the faculty on the AUA 2026 website. We're going to use an ARS system, and so if you have your smartphones, there's sign-in, login information on the printouts on the page in front of you. We'll put a QR code up because that is how you will take our pre-test, and this is being recorded and will be repurposed and broadcast as a webcast and podcast. So if you have any questions, we'd appreciate it if you could try to get to the microphone, and then the faculty, we can also repeat the questions so that it is recorded for those further contents. Certificate of Participation, or CME, for both AAPA and ANCC. You may claim credit at the end from the AUA 2026 CME link or the mobile app. So I will bring up kind of obviously too much here for me to read through fully, but largely what we're focusing on is biomarker testing, both germline and somatic, incorporation of PARP inhibitors, PARP inhibitor combinations, safety and side effect monitoring, and potential patient vignettes that we're going to walk through to kind of highlight some of these learning objectives. So I'm going to sit down and run through some cases with the experts here with me to walk us through some of these issues. So this is a first case. These are all from my clinic. A 55-year-old healthy African-American male. You can see here moderate PSA elevation, a PIRAD 3 lesion, biopsy to found Gleason 4+5. He does have significant family history, mother and father, a sister with breast cancer. And a PSMA PET shows uptake only in the prostate. He undergoes local therapy with a radical prostatectomy, which you can see pathology T3A in one disease. So it was not visible on the PET on the nodal disease. And now post-operatively, his PSA is rising to 12, and we have a new PSMA PET, and you can see these are representative images from this patient. Avid bony lesions inside and outside the axial skeleton, as well as some retroperitoneal lymph nodes. And the patient is prepared to start ADT and combination therapy for metastatic hormone-sensitive prostate cancer. I think actually we'll start with you, Kristen. Could you discuss kind of your treatment testing guidance for a patient presenting like this with kind of newly progressive recurrent metastatic disease?
Yeah, sure. This is a challenging case.
Unfortunate, yes.
Yeah. So I think this case really highlights why it's so important for urologists to kind of quarterback care for patients throughout the continuum of prostate cancer, or at least collaborate very closely. I sometimes say prostate cancer is a team sport because it requires radiation, it requires surgery, it requires medical oncology, pharmacy, palliative care. It's so interactive, but this is where it starts. And this patient on his biopsy had high-risk disease, and even before you touched him and he shared with you his family history, I think that he potentially qualifies for genetic testing. So in that setting, I will sit down with the patient and say, hey, here's a test I'm recommending, and it's not just me recommending it, it is across guidelines being recommended because it can impact several areas. First of all, it gives us an understanding of your prognosis. So how aggressive is your disease likely to be? It also can tell us in the future if you are going to respond to certain therapies better if you have a mutation than if you don't. I say that there are therapies that are FDA approved that are FDA approved in the setting of a mutation that is associated with prostate cancer, or actually a panel of mutations. And then I talk to them about cascade testing as well. So what that means is, hey, if you have this mutation in the cells that you were born with, that you inherited from your parents, that you share with your siblings, that you pass on to your children, it is possible that other first-degree relatives also have this mutation and may want to get tested. And so I think the implications of it are far-reaching, and I feel comfortable saying to the patient, here are the possible outcomes, and here are the possible implications. And if a test comes back and says, hey, you do have a BRCA mutation or you do harbor this VUS, then I refer them to someone much smarter than me to talk about genetic counseling. And that can be in your own institution if you're fortunate enough to have a genetic counselor on faculty, or it can be through any of these companies that are offering germline testing. But I think urologists really need to be involved in the ordering and counseling of genetic testing for our patients.
So taking your language, I use that in clinic and basically then approached this patient when he presented to me, it was at the metastatic setting, and said, all right, we need all the testing for those great reasons. And he said, okay, what do you need? We sent off his prostatectomy specimen. And you can see here, this is his report, BRCA2 mutation pathogenic. And a lot of these reports they're all a little technically different, but they all list a lot of options. Now those options have changed dramatically over the years, but they do list options. And then he went through confirmatory germline testing. And first, before we move on, like in the BRCA2 setting, Pedro, now you've got a BRCA2 mutated metastatic hormone sensitive patient. What are you discussing with him today?
Yeah, so just a couple of comments on this. I think I'm seeing a BRCA2 there, right?
Yes.
So testing means two things, germline and somatic testing. The information we get from one does not replace the other, so we should get both. We're talking about a type of repair called homologous recombination repair, and so HRR, that's what we're talking about. So I may have a somatic alteration at the tumor level, or I might be born with an alteration in BRCA2, so I might get a germline BRCA. So altogether, it's probably a third or so of the quarter of patients with hormone sensitive disease. So, and the data that I believe was your question leading to, what does that mean from a predictive value? Speaking of prediction. So from a prognostic value means those patients are destined to do not well. Badass cancer, that's what it means. This means that irrespective of the treatments, patient is going to do not well. In the metastatic hormone-sensitive disease, if I offer DTRPI, I'm expecting this patient to progress around 2 years or so. Just give a sense, right? Median time of progression on DTRPI is maybe 3 years if you want to think of all comers. BRCA2 positive disease, I'm expecting less than that, right? So as I'm talking to a patient, I'm thinking ahead and thinking what might happen in less than 3 years. These are patients that may have more aggressive disease, means that I won't trust PSA as much. I'll do scans more often. That means conventional scans as well, and think of things like neuroendocrine features, et cetera, visual disease, et cetera. So to your point, going back to your question, as we offer ADT on first visit, and we're thinking of proving castration 3-4 weeks later, whether I do agonist or antagonist, and I do genetic testing at that point, the patient is treatment naive, so I would have done both. Tissue is not that old. I would have sent tissue out for tissue testing or somatic testing, and also a blood test for germline test, and I'll get both results a month later when patient comes back. So, so the point here is we do, when we can, we do pre-test counseling, And then the positive results, we involve genetic counselors to do the post-test counseling, I guess, which, by the way, the companies out there that we work with have those services available. So even if you don't have genetic counseling available at your center, you can provide those services to the patient as well. And then predictive implications or predictive value, you can tell your patient, look, I know how your disease is going to go, and it turns out that we actually have a different way of treating you because we know your tumor expresses BRCA2. And if I'm reading this correctly, this is a somatic BRCA2, not germline, meaning patient was not born with BRCA2, which it could be because he has such a strong family history. But that means I can consider a PARP inhibitor along with ARPI, along with ADT. It got approved, 5 months ago or so, niraparib with abiraterone, based on the trial called Amplitude, that has shown superiority in HR, particularly BRCA, which over 50% of patients enrolled in that trial harbored BRCA. And it's now standard of care for those patients. So if I'm the patient, if I have BRCA2, first of all, I want to know. I want my team to tell me what that means. And number 3, I want to be offered a treatment that is able to drastically change tumor control for the better. And then we'll see what happens overall survival because it's still immature, although the trend is there. So PARP inhibition is a conversation that we now have in this setting, and we used to have in the CRPC setting up to recently.
So I think I jumped the shark. This is the hottest off the press disease state for a PARP inhibitor.
Right.
And I put it here to kind of generate discussion around the fact that we've always saved testing for the end. It's like worst case scenario, we're looking for our last straw. But this is kind of the call to action that we now have tools to use earlier. We didn't really years ago, and so you could make the argument to wait. But I think now these cases really hammer home the fact that we can't wait for testing for these patients.
Right, so it's a couple of comments to make on that, and I'm curious to hear my thoughts on my colleagues on this, but there's a number of questions. So number 1, we lose half of the patients every time we move from one line of treatment to the other. So whenever we find a marker, the fact that we know about it doesn't mean we can do something about it when the time comes. Patients progress, do worse, and disappear. If you look at real-world data, we have a sad drop of about 50% each time. So we treat about 80% of patients with metastatic disease, only about half or so get second line, all about 20-ish% get third line. And that's a scary reality. The second piece is, if you have a BRCA positive disease, that means your tumor is destined to do worse. So the outcomes of those patients worse than when you think of a pool of patients with metastatic prostate cancer. The third aspect is, if you don't test, you got to wait for the results. So a lot of the testing is done as a pre-hospice or desperation move. So we never find a time to see the results and do something about them. Right? So it's another reason to do it early on. And fourth, which maybe is one of the most important, is we actually have level 1 data, phase 3 data to do it at this point, or Monsanto's disease, or first-line CRPC, if you will. So there's really no reason not to do it. I would argue the final comment I'll make is there's an academic study that basically look at sequence versus combination, and that brings the point about doing earlier versus offering upon progression on RPI, where on that academic study, at least the patients who received the combo, meaning got the PARP early, were able to do a lot better than adding the benefit of doing an RPI followed by a PARP or a PARP followed by an RPI. So when you put all these together, absolutely is a big call for us to test early, act on it early.
Kara, I'd be interested in your input because as a PA in a community practice, you and I both practice differently than an academic tertiary center, and a lot of our audience here probably similarly. What is your role in terms of prostate cancer management in the clinic? Do you bring up and discuss testing with patients? Do you help with pre-test counseling and patient identification? Because often in clinic, for the urologist, it's so busy. We're just trying to make a treatment decision, much less talk about testing. So what's kind of been your role on kind of that education front?
Yeah, so in our practice, we have, our APPs have a touch point with most of our advanced prostate cancer. So they're generally diagnosed by the urologist, and when they are requiring additional hormonal therapy and oral therapy, they tend to come over to our APC clinics. Anytime that there's a touch point, I think with any provider, so specifically with us, we do try to do it up front, at least the germline, and then make sure we're reviewing the pathology, and if they're meeting qualifications for somatic testing, meaning that they're metastatic, getting that tissue out to be tested for somatic mutations. But any touch point. So where I found it's most successful is anytime a patient is having a blood draw. So it's like if you're asking someone to do something else outside of what they would normally be doing, sometimes it's a little trickier, but it seems to be, and for hopefully most of you guys are seeing them on a routine basis, generally probably every 3 months, where they're getting their testing and they're sort of being monitored for their treatment response, depending on what they're on, maybe even more frequent blood draws. But any touch point, so what I generally say is, hey, we go through the beginning, like maybe I want to say, what is their initial testosterone, what is their PSA now if it hasn't been tested, what is, their CMP, what is their CBC, and then I say, oh, and by the way, we can actually do some testing to see whether or not you carry a mutation based on your parents have potentially passing it on. So looking at the state of the disease, looking at, so basically testing the appropriate person. But in this particular case, since the patient is metastatic, they do meet qualifications, getting them tested, and then at the next touch point, kind of going over those results. So any touch point at any point, and I think it depends, where APPs have their role within the clinic. But if they do have that touch point, then you should definitely use that, because it does take a while.
I think that's the backup for those of us that are the surgeons, is that sometimes we run out of time to get all of that stuff done. And this is a case like localized disease that probably would have had appropriate testing if we'd had someone else to help share the burden of getting the testing ordered.
Yeah, for sure.
So we'll move on to the next case here. 75-year-old outside urologist had diagnosed with high-grade disease, and the decision was just monotherapy ADT. Not obviously ideal
I'm glad this wasn't your clinic.
In a lot of ways. I very clearly wrote outside urologist on there. And PSA did great for 7 years. Now, but you can see that this is part of the difficulty we have in managing an aging population. So now we're 82 and we have a PSA rising, and we say, well, actually maybe you're localized, we should treat you. And so he did actually have radiation therapy. And then now you can see 6 years later, he's 88 and his PSA is rising, has metastatic disease confirmed on imaging, and starts abiraterone. So he's a first-line metastatic patient starting abiraterone at the age of 88. And now here we are 4 years later, and now he's metastatic CRPC and his PSA is rising further. And you can see this recurrence of a lesion in his bladder that was actually a localized recurrence. And so he underwent a resection of this. Would you test at progression? So this is somebody theoretically we would have tested early on. I think all of us, are people testing now at, the test somatic may have been negative up front, but here we've put you under treatment pressure for 6-7 years. Would you retest this patient, Pedro?
So it's a loaded question, right? Because first of all, asking for retests in the absence of this case probably has an answer that's different, right? Yeah. We'll look at a 92-year-old. I'm not sure about the tumor burden today. And if I'm testing, I'm going to get first of all, what tests are we talking about? And number two, what do we mean by that? Does that mean we're going to sit down with a 92-year-old and I'm going to share a prognosis that might be different from, he's been dealing with this over a decade, right? And number two, am I going to treat him differently? He's 92. What is his life expectancy? So we have to adjust what we're doing to the patient in front of us, right? It sounds odd to me to close my eyes and say, oh my God, let's say you do have a BRCA, but by the way, you have 2 spots of the disease, and here I'm going to throw the sink at you. Unlikely to be the case, because natural history have shown us he actually hasn't done bad at all, right? So can we test? I guess the answer is never wrong, but I do think we have to have some critical thinking about why we're doing it, or what's the intention, right? So if I'm not ready to do escalation of treatment because I don't see the need clinically, I'm not sure, I might do it if a patient is informed, but doing something just because it says that I should do it, I'm not sure that's the right answer all the time. So the discussion, if we take this case away, our conversation is helpful in regards to retesting, right? So when you retest, so 2 things, germline, you should have the same results throughout your life. You don't change what you're born with from mommy and daddy. What you get is what you get, is what you have, right? So what changes though is the companies you use to do the test, remember what they're doing is they're matching your result against a database that keeps being fed every day, right? So thousands and thousands of cases being added to the database. It is very possible that today alteration called unknown significance, I have no clue if that means a problem today. Maybe 10 years from now, we found out that that specific alteration now is linked to melanoma. And so 10 years from now, the same report might have an amendment to say, hey, by the way, your VOS in 2026 means likely pathogenic in 2036. So we should be getting updated reports if that's the case. That's not what you're asking me. You're asking me about somatic. Somatic testing, so when we repeat it, for the most part, is for research purposes. So I would love to say, let's do what I used to do at Tulane, where we had an average of 3 to 4 genetic somatic testing per patient. But to quite honest with you, how many times do we change our practice based on that? I'll tell you, almost never. So my call wouldn't be to repeat it and repeat it and repeat it. Yes, there are cases of acquired resistance. As we know, BOLA for PARPs, MSI, you can acquire that, but those are rare phenomena. So I think it's a reasonable request or a reasonable thought to say, I need to have somatic testing upon MCRPC. I'm going to do something about it. In fact, since December, I should have somatic testing upon metastatic disease, along with germline testing and localized high risk, recurrent, and metastatic disease. And the retest provides limited value today for therapeutic implications. We do it mainly for research purposes as we investigate mechanisms of resistance, things that change over time, as you said, treatment pressures, things like emergence of neuroendocrine tumor, like that cancer that lost the zip code, it forgot it's prostate cancer at some point, and we start treating them differently, right? But that's the exception still. So the call would be, think of germline, think of somatic upon metastatic disease, and it's far more valuable to go from no testing to get those tests done than going from one somatic test to the second, to a repeat one. And if you use a CLIA certified test, you're fine. Be careful, because we're talking about whole genome sequencing. We're not talking about hotspot panels. So when I speak about testing, I'm not referring to a panel that I'm doing with my pathologist where I just check for BRCA2, nothing else. That is extremely incomplete. We need to go after, if you're talking somatic, you should look at DNA, old genome, that means DNA sequencing, RNA sequencing, protein sequencing, if you will. That is different from the hotspots or the little panels that we do just to find 1 or 2 genes. That is not what we're talking about here. And the germline, same thing. We have panels over 80 genes for all cancers, if you will, right? Look for things like Lynch, etc. So think of the type of test that you're using in addition to the timing of the test that you're employing.
So, Dr. Scarpato, this was a very healthy 92-year-old, but I just bring it up as he's saying to me, I'm not ready for chemo. Yeah. I'm obviously getting worse. This was his first test. I mean, I bring it up as a question of repeat testing, which I think we would all do. But here's his first test. It's a CDK12 mutation. He's on abiraterone and, quote, progressing. So are you, at this point, would you be considering anything specific for a frailer, even though very functional 92-year-old? Obviously, it may be a different question at 70. But does it impact your decision? I mean, I probably wouldn't have tested if I didn't think he was capable of getting a PARP inhibitor. But what is your thought on someone who's been on abiraterone or one of the ARPIs? Because a lot of our treatment is monotherapy versus combination. What is your thought on where we go with combination in somebody who says he's been on abiraterone?
Yeah, I'm glad he's robust at 92 with the treatment he's been through. And if the patient's telling you that he's not willing to pursue chemotherapy at this point, and you have a test result that maybe suggests that there is a treatment that may be better for him, I think it's worth the discussion for sure. The CDK12, in my understanding, is a little bit interesting because in some places it says it actually doesn't really respond well to PARP inhibitors, and maybe using immunotherapy is better in that patient population, but there is some maybe newer data showing that combination therapy with niraparib might be beneficial. So I think if the patient is fully counseled that here are the possibilities and here are the possible side effects, you can certainly consider that.
Kara, in terms of toxicity monitoring, we do a lot of shared care in the community between APPs and in academics too, with the APPs kind of bolstering our support for patients. What's your kind of monitoring for toxicity for these sort of patients when they're on a PARP inhibitor?
Yeah, so Things I think you need to consider. So everyone is probably very familiar that anemia is a valid concern and, affects roughly 50% of people who are on PARP therapy. So I think, making sure like the baseline CBC, what is their H&H, do they have, any like platelet deficiencies, what is their, renal situation look like, what does their liver situation look like? So, there could be various toxicities as far as, the laboratories, but also as far as toleration. So, the standard is, checking the CBC, on a monthly basis, but if there are concerns that, there could be some resulting problems, even checking an interim. But I think the discussion really, may surround, like, do you prophylactically treat some of these patients based on, concerning toxicity? So if you're worried, for example, about like nausea, do you, start some, the Zofran ahead of time prophylactically? Do you, are there things that you do if you're concerned? So I think a lot of it is discussing, the potential, maybe seeing how they're doing. So maybe you have, more touch points instead of like, oh, hey, here's the standard we see in 3 months, at that 1 month when they come back, seeing how they're doing, how are they tolerating everything. Additional considerations could be, instead of starting at full dose, consider starting at a lower dose and then titrating and working their way up based on toleration, rather than going all in and then patients have a hard time tolerating it and now you're trying to catch up and go down, and where do you go half, do you go whole, like what does that look like? And then, maybe if you're noticing certain things like, the anemia stuff, that's a valid, consideration too of, starting lower, and sort of working your way up, to see how they're doing, because if they keep trending down, then that could be a problem too. So I think you just have to kind of look at the whole patient. You have to kind of consider all their risk factors and then really talk through what that could look like, and then, just doing the appropriate monitoring, laboratories, and symptoms.
So Pedro, from a med-onc perspective, obviously you use a lot of toxic therapy, worse than PARP inhibitors. PARP inhibitors for a urologist is, a bit progressive for a lot of us a few years ago. In terms of counseling to the patients, what specifically do you warn them about before starting in terms of toxicity to look for, expectations in terms of dosing? Is there any guidance that you give most of these patients when you're starting them?
Yeah, there's a few things that come to mind. So you're going to need 3 to 4 months to find the cruise control dosing for your patient. So most of the side effects and, anemia, as you said, is probably one that we care, that may or may not be symptomatic, depending on the studies. They were, you can see about that, and some need for transfusions. The aspect that a lot of these patients do have some degree of anemia baseline, so it will require some kind of workup. So I explain them, we need to make sure there's nothing else contributing to your anemia, so that your anemia doesn't get worse for another, whether it's low iron, vitamin deficiency, etc. Right? So doing that workup up front is relevant. Explaining some GI alterations is important. Explain the cytopenias is important. We talked about anemia. I don't necessarily, we try to be as thoughtful as we can about the conversation. Of course, in the back of a med-onc, is always the story around secondary malignancies. So elderly population, MDS, AML, it's not common, it's infrequent, but it's reported, and we always think that. So pay attention to the numbers, the counts in the blood. So that's something to keep in mind. And also the clotting, the thromboembolic events is something that we keep in mind as well. So just FYI. So we have those things in mind. I will say, if you look at the quality of life data, once you find the right dose around month 4 or so, you pretty much set. So you know what the patient can handle or not. And I agree, adjusting the dose. It is true, though, that in the med-onc world, every time we start low and we say that we're going to go back, we never do. So I would encourage, whenever possible, do the dose that you think is going to be efficacious, and adjust as needed. And don't start low with the attempt, to go up, because the merit is there. But in fact, the data seems to suggest that we never get to where we would if we were to start otherwise. It's the same in the kidney cancer world, where we're just trying to figure out the right doses for TKIs. It's always like that. If we start low, we never get to the right dose. Which for some people is not wrong if it's working, right? But just keep in mind, there's a reason why on the protocols we started that dose and we came off with dose -1, -2, etc. So those are some of the aspects that come in mind. Of course, depends if you're considering monotherapy or combo. There's certainly a different safety profile if you do a PARP by itself, which, by the way, for the most part has been olaparib, post-ARPI, that's what we were saying, versus a combo. The tricky part about your case, this, in addition to being 92, by the way, but the tricky part is the CDK12. When you look at the aggregated data, we don't see much signal in the CDK12 for monotherapy. I'm one of the folks who, if I see a non-BRCA, I tend to use a combo, not monotherapy. But it is approved. So you might get a genetic report, CDK12 recommendation level 1, CDK12. However, well, here it is. However, if you ask one of us, a GU med-onc will be telling you on the phone, yeah, you know, we haven't really been doing that, right? And so it's like, what do you mean? And that's actually a complicated conversation with the patient because the patient is reading it and you're telling them not to do it, right? So we have actually recommended against in many cases. There's all these specifics. Patient doesn't want chemo, he wants to give it a try, he's fine, he's not symptomatic. There's all these cases we can come up with. But you look at the signal. We actually have a beautiful paper around immunotherapy from Emmanuel, right? The immunogenicity around CDK12. Some might not even consider part of the real deal for the DNA repair, if you will, and I'll leave it at there. The point is, the signal doesn't seem to be the same on the CDK12 along with other genomic alterations as it is for BRCA. So it'll be harder for me to offer, a PARP, in the context of a CDK12 where the patient is. But that'll be my personal opinion.
I think, obviously, BRCA 1 and 2, slam dunk.
More two.
On the other,
yeah.
yes, more two. And one seemed to be a little rarer, at least in my experience. The other end of the spectrum is the ATM, which everyone thought was going to be great. And honestly, this signal has been less ideal.
Right.
PALB2, somewhere towards the positive side.
Yes.
But then there's a whole host of genes.
But you still have the FANCA, RAD51, HER, there's a bunch of them.
I've got a slide at the end that actually shows, and the labels are all different for many of the gene sets. So you just have to look into what the mutation is and know that not all of them are created equal.
Yes, and so keep in mind, just a review, so you have two PARP approved as monotherapy for CRPC, not hormone sensitive, CRPC, olaparib based on PROfound, rucaparib based on Triton. Remember the Triton 3 limited in the context of, basically for PROfound you do all HRR, but you're limited in the Triton mainly, you talk about BRCA, right, for the most part. And then for the combos, you have approvals for BRCA with olaparib and abiraterone, niraparib with abiraterone, and then telzaparib and enzalutamide. And the latter is the one that got approved in the context of HRR, and the others applicable to BRCA. So as you can tell, it's very nuanced, right? And by the way, the combos were all of this was actually explored post-ARPI. So they were not for the monotherapy, but they were ARPI naive or not ARPI not progressors in the combo. So this patient is tricky because if you want to do a combo, it's a post-ABI setting, for which we don't have much data. So it's not that we can be seated here recommending a formal recommendation for a combination because you really don't have that data. In other words, you don't know what the addition of ARPI to a PARP inhibitor gives you in the context of an ABI progressor CRPC patient.
All the nuance of this, which is why if you don't feel comfortable, the easy take-home message is test.
Yes.
And then get it to someone like Pedro who's down the street who might be willing to spend the time to walk through the nuance.
Right, we can chat and we can talk and kind of share experiences, right? It is not simple, and this evolved very quickly in a relatively short period of time.
Last case here for review, once again, another young patient. You get a little bit of a signal for young patients with bad genetic disease. But you can see here, high risk 4+4 in 2017. So that would have been pre-approvals for anything. We had no guidance on testing. Germline was just a thought process for HBOC, for hereditary breast ovarian at the time in 2017. A couple years later, had a prostatectomy, T2 disease, unfortunately persistent PSA after the prostatectomy, and had salvage without hormone therapy at the time. That was the guidance. He had complications of his salvage. He had an Oxman PET scan. At the time, no PSMA approved in the US. And then eventually did have a PSMA PET when the PSA kept rising, and then started playing whack-a-mole. So the current era of like MET-directed therapy with or without ADT, and this was a young patient who was saying, I don't want to be on ADT forever. And so, but you can see some benefits. There were plenty of periods of time where we eugonadal without progression, but went through 2 rounds of MET-directed therapy. And then unfortunately had this period where the PSA started really rising even while on ADT from his MET-directed therapy. And so he is now castration resistant, and unfortunately new imaging, and the images don't show here, but he had multiple bony lesions of uptake. So this is kind of presented as the same sort of situation. This is someone now who's metastatic CRPC, who's just been on ADT monotherapy because he was getting MET-directed treatment at the time. And we're saying, all right, fine, we're going to add an ARPI. This is your first line CRPC. But now we're taking a step back because this patient had never had any testing from 7, 8 years ago. And so I share here basically genetic testing this is the somatic report, and one of the nuances here, you can point out variant allele fractions right around 50% for BRCA2. So that's a suggestion that there could be a germline component of this. It's about half the cells have BRCA2 mutation. And the family history here, you can see a mother with breast cancer, but no history of prostate cancer. And so he did go forward and get germline testing as confirmation, as what we've talked about already. Dr. Scarpato, liquid versus tissue. This person's tissue was old. I mean, his prostatectomy is about 6+ years ago. So what are you offering to patients that present like this that need testing now but don't have anything fresh? Are you doing fresh biopsies? Are you using liquid testing?
Yeah, in a metastatic patient, I would recommend and order a tissue biopsy. That's where we are now, and I think that's what the data is most in support of. Liquid biopsy is an exciting alternative that has a growing body of evidence in support of it, but I don't think it's quite ready for prime time in all patients. And so it is, I think, a guideline-based recommendation. My recommendation that we get a tissue biopsy for analysis.
Kara, I'd be interested. Community, this is bony progression. Are you doing a lot of liquid, or are you trying to get metastatic biopsies?
Yeah, we're not really doing repeat biopsies. We're getting more liquid at this point.
Pedro?
Yeah, so when tissue is available, we'll get tissue. We do a lot of liquid biopsy, so 2 or 3 pearls, I guess. One is the concordance rate between liquid and tissue is over 80%. Actually, I think a paper just came out on Propel looking at tissue and liquid, and the concordance is quite high as expected. There's a little niche more that you can detect, but if you don't have tissue, so the thought process, the take-home message is, if you don't have tissue, don't give up on testing. Just go ahead and get liquid biopsy. Now, there's some things to take into consideration. The timing of the testing matters. Do not start a treatment today and do liquid biopsy 3 weeks or 4 weeks from now, because you're less likely to find viable DNA in the blood, to sequence, right? So always do it upon progression when you're expecting to see it, and that's an important aspect. For very low tumor burden, you might not detect anything. That's the other aspect, right? So with that said, this is he's screaming germline, right? 48% allele fraction is extremely high. It's extremely unlikely that one tumor pick it up. And by the way, the other thing, these tend to be truncal. What that means is early on in the development of prostate cancer. So it will be rare or not common to find HR alterations. Late line, you tend to see them earlier, and that's the other benefit of you wanting to test earlier as well. Like it's not like, oh, I might miss many cases. No, it's actually they are supposed to be truncal for the most part. So anyway, we do a lot of liquid at our center, especially for the recurrent cases, as you said. Surgery done many years ago for whatever reason, bone only. We have that issue with the decalcification in the bone, finding viable tumor when we have the bone mets. But I agree, it's still considered gold standard. Also for trial purposes, whenever we can, just get a hold of the tissue. Yeah, I agree.
So this did turn out to be germline confirmatory. And so this is the treatment sequencing I think we're faced with in clinic. You'll often start a therapy without having testing back. But that does not mean you should not start the therapy. And sure enough, when this test came back, he'd already started enzalutamide and started responding. So I presented the option to him based off the TALA-2 study of talazoparib added to enzalutamide, and he agreed and elected to proceed. And so now it's been approaching 2 years now, combination, still with excellent PSA response. But I guess this is also a call to action for me, and that he would have probably benefited from his germline testing back here in 2017 when he had high-risk disease on his biopsy. Because if we'd found the germline then, would it have changed what we did for his treatment? And I don't know. I mean, granted, we're 8 years later. I don't know of any data that says we would operate any differently than we would have back then with prostatectomy. But Kristen, any thoughts about, like, does it change and influence your decision when you get germline results on patients who are still in the localized setting? Or are you just warning?
It does in the localized setting, maybe not necessarily in a patient who's high risk. I might counsel him that his risk of biochemical recurrence is higher, his risk of developing metastatic disease is higher. His outcomes we know are not going to be as good. Even if I have a great surgery and he didn't have a BRCA mutation, I would expect that he would do better. But certainly in someone who's like an active surveillance candidate, if we were to get BRCA testing based on family history and he was positive, you know, that's a little bit tricky. We know that the relative risk of detecting prostate cancer is higher in that patient, and then again, higher risk of kind of unfavorable outcomes. And so I might be less likely to keep someone on active surveillance if they had any small amount of grade group 2, or if their MRI showed a really kind of ugly PIRADS 5 lesion, or if their PSA density were unfavorable. Whereas I'm very comfortable watching patients who have low volume grade group 1 right now on surveillance, and I think that you just counsel them that their risk is increased and maybe your frequency of surveillance would go up on that patient.
Peter, you've already touched on monotherapy versus combo. Can just a little bit of the science behind why combo was initially tested, what the theory behind why it might apply even in non-HR cases, because there are plenty of trials coming that also include non-HR patients. Just a comment on that.
Sure, just to keep it simple. So actually the story has been going on, or the understanding or the knowledge has been around for over a decade, you know, since the lab work and then clinical preliminary results. So bottom line, you have the androgen signaling pathway, and then you have these, you know, DNA repair, so the genes that lead to that repair system. Specifically, we're looking at homologous recombination system. And so what do you see in the lab, and then I guess we saw that, you know, in the form of phase 2 studies, and then with the phase 3s that ultimately led to the approval, is, you know, basically there's a relationship between these two pathways. So when you inhibit the androgen signaling pathway in a potent manner, you're able to, it's almost like you transform the HR intact vibe or environment into HR deficient, if you will. So, and vice versa. So when you suppress the HR component, you will see an overexpression of AR genes. So there is, again, preclinical as well as clinical data to leverage that. I don't want to be controversial, not controversial, I don't want to be provocative, because in fact we've seen that not only for patients who have HR deficient tumors, but also for patients who have HR intact. And quite frankly, that's what justifies the all-comer design studies that we've seen with PROPEL or TALAPRO-2, for example, where we actually look at patients who present with CRPC, whether or not they had HR alterations, because there was leverage on the knowledge that was acquired from preclinical and clinical data. And just going to call out, you know, the phase 2 from Noel Clark is I believe is a Lancet paper. You see that with Lapre Banabri. Look at the 4 Kaplan-Meyers there. You know, you can look at the data from Fred Sad, which is the phase 1 for Nira Abi, and finally you can look at the part 1 for TALAPRO-2, which is a Niraj poster. I don't think the paper's out, but the phase 1 part of the TALAPRO-2, which is a form of a poster, I believe was ASCO GU, you basically kind of, you know, leverage basically the safety of the combination. But in short, that's what I said, is those pathways, you know. And what was the other question?
I think that was it.
Okay, and so just to say, you have both NIRA and olaparib combined with abiraterone as backbone, and then Talazo combined with Enza, right? There's a lot of stories behind why those combinations specifically. They have TROP activity. They're different PARPs. They're not me-too drugs. They seem to be not exactly the same. They have different trapped features. You know, olaparib, talazoparib seem to be well positioned with the trap activity, and there are novel ways of blocking PARP, like PARP1 that we're seeing in the EvoPARP program, for example, etc. So it's an ongoing story.
So that was one of the pre-test questions, was around PARP1 and PARP2 activity. Yeah. PARP2 potentially being more hematopoietic, and so if you spare PARP2 inhibition, there's the theory that maybe it doesn't suppress bone marrow activity as much. obviously playing out in some of our ongoing trials. We don't know.
Right. The data that I'm aware, I believe it's called Petrania. I believe Zarun Azar presented that. It was combined with the RPI. And so, I'm not sure I've seen a lot of data with a PARP. The therapy that I'm aware, or I'm referring to, is called saruparib, by the way. It's part of EVO-PARP program. There's a number of large phase 3 trials ongoing. Looking at the biomarker-directed therapy is a PARP1, selected for PARP1. So you save, as you said, save PARP2. So in theory, you'll have a better tolerability or safety profile. We'll see if that pans out. And so I think that's what we know so far. We'll see if he's able to replace. If we see the same signal efficacy-wise and better tolerability, there is a world where they would replace the PARP inhibitors as we know them, as we use them across solid tumors, and so that's ongoing.
So with that, I thank you all for your attention and your time this evening, and there should be surveys, so we'll go to them. Okay.